Good afternoon everybody. And so good to see some of you coming back into the room. We have a full room for session 4. My name's Crystal Oldman and I'm the Chief Executive of the Queen's Nursing Institute, which is the oldest nursing charity in the world. And we support nurses who work in every setting in the community. And I also have the privilege of being a Nuffield Trust trustee. And this session, thank you, Thea, for giving us, where's Thea? Thank you, Thea, for giving us so many difficult sessions. So this session is why is it so difficult to get end-of-life care right? And against the backdrop of the research evidence that we'll see presented by Sarah Scobie and the perspectives of our fantastic panel members here, we will begin to understand more about why it's so difficult to get end-of-life care right. Now, I know that this is a very emotive subject, and as a nurse, we talk about death and dying all the time. So it's kind of like our bread and butter, but for a lot of us, it's not. And it always brings up emotions about somebody that you might know, a loved one, a relative, a friend who has died recently, who is dying currently. So we do understand if this is too much, please think now whether you want to stay in the session, and we totally understand if you need to leave during the session. When I used to teach this at the university, we often had students who left part way through the session. And there are a number of us here who are clinicians, and if anybody wants to talk to us afterwards, of course, you're more than welcome. And whilst we're not focusing this session on assisted dying, we know it will come up. And Mark Mardell, our panel member, will definitely raise this as an issue. But we don't want that to be the single focus of the session. We want to be able to answer that question. Why is it so difficult to get end-of-life care right? From the Queen's Nursing Institute perspective, we've surveyed the workforce which provides the vast majority of person-centred, holistic end-of-life care in people's homes, the District Nursing Service. And we've seen a depletion of that workforce over the last 10 years of 50%. They are a core nurse, specialist nurse, giving care, end-of-life care in people's homes, and yet the initiative, the 10-year plan, is going to be focused on one of those three things: more care in the community, 50% reduction in district nurses over the last 10 years. That's NHS data, that's not Q&I data. But our latest survey of the district nurse workforce, published last year, 2024, showed that district nurses were so depleted and so stretched that unbelievably they were deferring end-of-life care. This will be people in their last weeks, days or hours. And I've never seen that in any of the work that we've ever done. I've never seen that. So I asked Professor Alison Leary, who had done this work for us, if this was right. Alison never gets anything wrong. And she said exactly the same occurred to her. So she went back to the data before she shared it with me. She went back to the data to check that this is what district nurses had said they were doing. So deferring work left undone, and we have one chance to get this right. And that was because of the stretched workforce. And imagine the moral injury for the nurses not being able to do because they have not enough time to do it. So workforce won't be the only reason why we're not getting this right. But given the reliance on expert nursing workforce and others, and I know Vic is going to talk about others too, given that expertise, it will be one of the factors, but we're going to explore many. And I'm delighted to be joined by the panel members, who I will introduce as we enter into the session after Sarah has woken you all up with something, actually. She's going to do some interaction with you in just a moment, and then we're going to move to the panel discussion and lots of questions, and I know lots of you will have questions. So first of all, over to Sarah. Thank you.
So thanks very much, Crystal, and welcome everybody. And I think you'll see on your table a Mentimeter thing to scan. So if you scan that to start us off, it's also up on the screens. You'll be able to open Mentimeter, because the first thing we're going to do in this session is a bit of an audience Q&A. So we're going to be asking how much you know about end-of-life care to start us off. So I'll give you all a minute to get Mentimeter loaded, and maybe give me a little wave when a few of you have got that loaded. Great, a few little waves coming up. Excellent. Waves, any waves from the back? Very good. Okay, great. Lots of people waving. Excellent. So I'm going to start with a series of questions. The first one I think is up now, and what we're going to do is go through these in turn, and you get a chance to answer. We'll give you a moment to do that, and then we'll see how you do. The results will come up, and then I'll talk through the answers. We've only got 5 questions, but it's really to get you thinking about what you know about end-of-life care. So to start with, what proportion of people die in hospital? And hopefully you're putting your answers in, and in a second we will see what happens. Okay. Great. So I think that's probably a good spread of answers. A few more might still be coming in. So maybe let's go on to the answers. So actually, quite a lot of you didn't get that right. So the answer is 43% in England and Wales over the last couple of years anyway. And the proportion of people dying in hospital has been declining over time. At the start of the pandemic, there was a big jump in the proportion of people who died at home. So in 2009, that was 24%. It's now around 28%. And back in 2004, it was 18%. So the proportion of people dying at home has increased considerably. But still, 43% of people dying at home. Dying in hospital. Okay, so we go on to the next question. So this one is about preferred place of death. What is patient's preferred place of death? And there's 3 options for this. And I'll give you all a moment to answer. And then we'll see what answers are coming up. And of course, do chat on your tables. You don't need, this isn't like a personal test. I should have said that at the beginning. You are allowed to confer with your neighbours. See if that improves. See if that improves your performance. See if you can do a bit better on this question. Okay. So hopefully people have answered. Okay, very good. So that is a much better performance. Thank you for that. So if we go on to the answers then, indeed, of those options, home is the preferred place of death. Now, it has to be said, the research evidence about this is always a little bit uncertain, because what people prefer in a theoretical sense and what actually happens and how they feel when they get near a death may well change. But the preference for home-based care is quite strong from a lot of studies, and actually the preference for hospital care is stronger than for hospice care amongst people who've died of cancer. And some of the reasons why people prefer home-based care are being surrounded by family and friends, more autonomy and dignity, and it being associated with a peaceful death. And reasons why people are not so keen on a home-based death is distress about death itself and symptoms, family burden and lack of support or the inability to provide care at home. So moving on to our third question, which is about the impact of deprivation. So what is the life expectancy for men in the most deprived decile in England? And again, do talk to your neighbours. Okay, very good. Wait for a few more responses to come through. Great. So I think we have most people's responses now, and most of you got that right. So it's 74 years for men in the most recent data, and the chart actually shows life expectancy for men and women in the most deprived and the least deprived. So there's about a 10-year gap for men and slightly less for women. And I think just something to also bear in mind is that as well as the difference in life expectancy by deprivation, we also know that people in more deprived areas are more likely to be admitted to A&E at the end of life, to attend A&E, to be admitted to hospital and to die in hospital. So there's some really important differences to understand in the experience of death and dying and end-of-life care with deprivation. So we go on to our next question, and there's only this one and one more, you'll be pleased to know. So what proportion of healthcare spend in the last year of life is on emergency hospital care? A bit of uncertainty. Numbers going up and down here. Great. So if we move on to the answers for that one, and I do feel a little bit cheated actually because the BBC covered this research today. No, it's obviously good that they covered it, but they had to do it today before I gave you this test. But hey. This comes from analysis that we did with the Health Economics Unit for Marie Curie. And we estimated from that of the spending on healthcare, about 80% is on hospital care and 56% is on emergency hospital care. So a huge proportion of what we spend on people in the final year of life is spent on emergency admissions, A&E, and really very small proportions on other things. And for social care colleagues in the room, of local authority expenditure on end of life, we estimate that around 80% is on residential and nursing care. So again, a very similar focus on care, on bedded care, if you like. So, final question, moving on to a slightly different topic. What proportion, which country has the highest proportion of deaths which are assisted deaths amongst the three shown up here? And again, do discuss with your colleagues. So I think we've probably got most of the answers now. And the answer is actually the Netherlands. So we're doing a piece of work at the moment to understand the lessons that the UK could learn from countries where assisted dying is legalised. And as part of that work, we've been going through reports about assisted death in different countries. And so that's the source for this data. It's interesting that there's a really wide variation in the proportion of deaths that are recorded as assisted deaths. In many countries where it's legal, it's under 1% or thereabouts, but it is highest, as far as we can tell, in the Netherlands. But I think one point just to note is that even in these countries where it is relatively higher, 95% of deaths in the Netherlands are not assisted. So just to also put that in give that context to our discussion about end-of-life care. So that is the end of your homework now. So thank you very much for participating in that, and we'll move on to the panel.
Thank you so much, Sarah. That was, well, we've both learnt something here, because I would have said straight away Switzerland, and Mark has just informed me that that is absolutely not the case, because it's not assisted dying. You have to self-medicate. Yeah, so I expect you all knew that, but I've just been taught that. So every day is a school day up here.
I hope that's right.
Thank you so much, Sarah. So Sarah, who is the Deputy Director of Research at the Nuffield Trust. Thank you so much for that. You're joining us on the panel. And for each of the panel members, I have posed a question to you each, and you're going to give us a few minutes in answering that question. And before you do, I will introduce you. We're going to start with Mark Maddell, who's correspondent, Prospect magazine, but also known to me, and I know loads of the audience will also know you and know your voice from Radio 4 and the work that you did there.
Thank you very much.
Today programme, political correspondent, EU... North American editor. Fantastic. So, and it's just brilliant to have you here. And this is the question that I posed, which you're going to start with. And the question is, what's your view about what we need to do differently with end-of-life care? And what would it take to get this right? So you're going to tell us something, Mark, about that.
I'm going to learn from you and I'll give you the answer at the end, because I'm not only the least expert person on the panel, I'm the least expert person in the whole room. In fact, I feel a bit of a fraud, really, being up here. And I do apologise, even though I have had such a good broadcasting career, my voice is weak, and you'll understand why in a moment, I think. So the reason I'm here formally is because I'm Prospect's writer of a blog called A Good Death, simply a translation of the Greek euthanasia, and which focuses around assisted dying. But the reason I got that job was because the editor, Alan Rushbridger, heard me on a podcast I do called Movers and Shakers, talking passionately about assisted dying. And the reason I do that podcast is because I've got Parkinson's disease, or condition, or whatever we're meant to call it these days. Anyway, I've got Parkinson's, and that means that I'm going to probably need end-of-life care more than most. I don't know that. No, you don't know that. Nobody knows for sure. But anyway, that's it's unpredictable, so it's a burden on my mind. It's not something I like to think about a lot, but I do, and then try not to, and then it's more than an academic exercise for me. Now, part of the point of my blog is that it's a learning exercise, as I say. It's a bit scary after years of the BBC, where obviously one had to be scrupulously objective. So what I tried to do is state my position clearly, unequivocally, that I'm in favour of assisted dying, and I think it should be, I started off thinking it should be wider than that, and because at the moment nobody's going to say if you've got Parkinson's you've got 6 months to live, so it automatically exclude people like me. I think it should or I did think it should have included suffering and such like. I'm not sure about that now, because part of the point of the blog is how I change my mind as I cover the debate, and I've changed a lot. Same is true here today. As much as I'm willing and happy to share my views, I'm also here to learn. As I say, I'm not an expert. I have lots to learn, and I like the phrase from the last debate about clumsy curiosity, so I hope I exhibit a certain degree of clumsy curiosity. I think everybody here wants a wide-ranging debate on all the issues raised, and is slightly hoping that the elephant in the room will sit quietly at the back, listening, not trumpeting, certainly not trampling on the wider aspects of the debate. But let's name that elephant. It is assisted dying, of course. I've been explicit about where I'm coming from. Having stated that, I also think the debate has been distorted by a number of things, and one of the main things it's been distorted by is a focus on assisted dying itself. The whole rationale of a good death is that it should be much wider than that. Assisted dying, if it was made law, would only affect a tiny, tiny proportions of death in this country. I think that's wider. There's a wider truth in that. Hospice care is only a small part, one part of palliative care, and palliative care is only part of end-of-life care. How you define these things does make a difference. I know you can argue that all end-of-life care is a form of palliative care. We're actually having this debate before we came on about, what is end-of-life care? Is it the last 3 days, or is it the year running up? Or I'd argue it's much even wider than that. But it became clear to me during the whole debate about the Ledbetter Bill, or immediately afterwards, that palliative care had been raised to a certain motherhood and apple pie. It could be no more criticised than cuddling kittens could be. So that makes me curious about it, and I decided to do 3 long interviews, which have really influenced, maybe I should have done more than 3, but I did 3. First with Sam Royston from Marie Curie, who I think is here. Hello, Sam. And that was great and very straightforward, and I understood a lot from that. Now, the next 2 really confused me, because the second and third were with Dr. Natasha Wiggins, who's a hospital doctor dealing in palliative care, Professor Sam Amazadi, who's also an expert. But they had the 2 last had diametrically opposed views, which left me feeling conflicted, to say the least. Sam, always suspicious when anything becomes a commonplace accepted wisdom. And I think among MPs, the answer that palliative care is the answer, the only answer, needs to be questioned a little bit. I know the hospice movement does a fantastic job, but as it stands, it only benefits a small number of people. More people, have we heard, die in hospital than if they receive palliative care. It's often just a label, in the sense that many of the doctors and nurses involved haven't been specifically trained for it. I was also struck by the professor's argument that the hospice movement only had itself to blame, and this is obviously controversial. But he said relying on jumble sales and cake sales was their fault because they had specifically rejected being part of the NHS establishment in the first place, partly because of their religious roots, partly because of their desire for independence. That independence, he argued, meant independence from taxpayer funding as well. He also attacked what he saw as the inherent conservatism of palliative care medicine. Now, you know better than I do, and I really don't know whether he was talking sense or nonsense. But he pointed out that while we've seen huge advances in cancer treatment and treatment of heart disease, he said palliative care had been stuck in the past. I'm willing to use modern methods. I'm willing to be more inventive, more creative, less conservative. Now, as I say, my blog is called A Good Death. Plato and Aristotle saw a good death as one that's dignified, peaceful, and in accordance with a virtuous life. But the real difficulty with that phrase is I don't think many people think any death is a good death. We are all going to die, and nobody really wants to. I mean, obviously, some people do, but very rare, I think, and very unusual. And that's why assisted dying is such a controversial thing. But I'm interested in the way we don't really think about how we'd like to die, how much control we have over it, and who, if anyone, should be there. And when I think about assisted dying, one of the things I feel it would give me is control over your own end. It gives you a sense of control, even if you never used it. And an amazing number of people, I can't give you a figure off the top of my head, but in those states and areas and countries that do allow it, an amazing number of people are actually prescribed the medicine and never actually use it. I think they're doing it to feel a sense of control at a time when everything's out of control. Because in many circumstances there is no choice. A heart attack, a car accident, you have no choice. But for many people there will be some elements that could be controlled, and I find it fascinating that this isn't discussed very often, because these days people plan their own funerals in meticulous detail, down to which version of My Way will be played and which sandwiches will be served at the wake, but no secular equivalent to the last rites. Not that I'm suggesting we need to forgive every part of our body for the sin it's committed, but I think there should be, perhaps, arguably, some sort of ritual surrounding death, or some sort of ceremony, I don't know. Sometimes simply holding someone's hand in a hospital bed is enough. But should there be more ritual, more structured way of making the moment? Should there even be gaiety, not grief at the end?
Brilliant. Thank you so much. Please thank Mark for that. That's brilliant. Well, you've certainly got us thinking. Thank you so much for opening up on so many subjects there. And whilst, as I did say, that assisted dying is not the main focus, I think you're absolutely right. We don't want it to be the elephant that's trumpeting everywhere, but we certainly needed to have that explained to us as well, about what it is and what it isn't. And also, we've all had a debate as panel members with Sarah about what the definition of end-of-life care is and what are we talking about. So it was really helpful to have that. Is it 3 days, 3 weeks, 3 months, or is it the last year of life? And how do we know it's the last year of life? So thank you very much for that, Mark. And we will come to questions when we've had each of the panel members answering the question that I posed. So next is Vic, and Vic Rayner is the Chief Executive of the National Care Forum. Vic, you might want to say what the National Care Forum is. I'm sure most people will know that.
I'm delighted to, very loud, up here. The National Care Forum is a membership body for not-for-profit care providers, social care providers. Great.
And so you're coming at it very much from the social care perspective.
Well, yes.
And you've already taught me something earlier on today about, okay, district nurses are not actually the ones that deliver most of the care, so thank you for that.
Okay, spoiler alert. So yes, I do want to talk about social care in this context and in this discussion. And I'm going to we've got lots of time to talk through many issues, but I wanted to particularly focus on the workforce, because I think the National Care Forum and a number of other care organisations are part of something that's called the Coalition of Frontline Care Workers, for those people who are working with people at the end of their life. And I think in the context of the debate that you started us off with, Mark, about what is end-of-life care, so I think there's an understanding in the social care sector, particularly in connection with older people, that we focus on what the British Geriatric Society have seen end-of-life care as the last year of somebody's life. So, and in the context of that coalition, one of the things that we really want to emphasise is about this huge generalist workforce. So the sort of 3 million people, in essence, who work across health and social care, who could well have contact and connection with people towards the end of their life. So there's lots of debate about how visible that workforce is and how much it's thought about when we're talking about end-of-life care. And I was reading this morning, as Sarah's alluded to, the research that was being described about how much money is spent on end-of-life care, whether it's successful or does the things that people need it to do. And I was really fascinated, and not to criticise the BBC, Mark, but in the context of what was there was a well, you can perhaps, but there's a description of where people die. So 20% of people die within care homes. 28.9% people die within their own homes. So almost all of those people, and including people who die at home, particularly older people who die at home, will have some connection with home care support, perhaps live-in care support, and certainly in residential care or nursing care, they will be surrounded by care workers all the time. And yet, throughout that article, there was a discussion about where money goes, where the workforce, the settings. There was nothing about care homes. Nearly 50% of people there were connected with care, and there was no further focus on the needs, the training, the support, etc. of those staff. So I think we need to, so I guess to your question about what do we need to do differently, I think we absolutely need to recognise the breadth of people who are connected with ensuring that people have a good death, the breadth of people who are front and centre often of people's lives in a way that's very different to the medical practitioners that they might engage with. It's very different to the nurse who comes and is part of administering or supporting somebody's palliative care. And of course those people are essential components, but often the person who is there with the individual waiting for the district nurse to come, or waiting for the appointment, or sitting in the A&E with the person who is needing that acute intervention is somebody from the care sector. And we have to think about how do we both recognise that input, that intervention, that support, that expertise that they offer, but also how do we recognise the training and the sort of core development of skills to ensure that they do that in the best way that they possibly can. So I think that's that's a really important part of it. And of course, I think the other bit from the workforce point of view is to understand what the impact of that is on those individuals. So if you're delivering that care, but you don't feel that you have the training, the expertise, and the right support to do that, that's a really hard burden to carry as an individual within that workforce as well. If you're working the reality is if you're working in an older people's care setting, residential setting, it's quite possible that the people you meet on the 1st of January, by the time you get to the end of the year, 70 or 80% of those people may not be with you anymore, and you may have been part of their death. That is, but not just part of their death, not just at the acute end of those final few hours or days. You've sat with them, you've supported them, you've helped them go to bed, you've laughed with them, you've held their hand, you've met their family, you know them, they're people who are part of your lives. And so I think that there's a really, so I suppose that's what I'm very interested in. How do we as a system think about ensuring that we recognise, we value, we support, and we have social care as part of that group of experts and expertise, and that we don't again sort of continue to have discussions which are about what happens in a hospital and what happens in somebody's home, without recognising that we need to have that social care investment recognition in there. And I think what I hear from social care staff and from organisations delivering social care is that they're often at the very sharp end of those shortages and challenges that there are in the rest of the system, and so they are having to either advocate or do whatever they can to make the lives of those individuals as comfortable as possible, and I think that would give us an awful lot of rich engagement, rich understanding of how we could make the system better. And we have a systemic problem, not just in the context of end-of-life care, but actually across all of the different changes we want to happen within health, the integration of health and care, is that we don't have social care providers having a strategic voice in local discussions. So if ICBs are thinking about how they might, establish a different end-of-life pathway or a different approach towards palliative care, it is going to have to involve social care, but the social care voice is not there as a strategic partner at the table. And until that happens, we're going to find it really difficult to properly ensure that all of the resources that are available to ensure somebody has a good life are put to good use.
Thank you. Thank you so much, Vic. Can we just thank Vic for that? And it's a really, really good reminder about social care and not being part of the narrative and the discussion. One of the mantras that we have at the Q&I for nurses, but I think we should extend this now, Vic, to social care, is be at the table or you'll be on the menu. And that's, about being done too. And that's what you've just made me think about when you said these end-of-life care pathways are being discussed by commissioners, but social care is not around the table. That's extraordinary. So thank you. Thanks so much for that. So
last but not least, is Dr. Libby Sallnow, who's palliative medicine consultant and Marie Curie Associate Professor of Palliative and End-of-Life Care at UCL. So,
Thank you. So I'll be speaking both as a palliative medicine doctor. So I work in the community in North London, seeing people at home, in nursing homes, in prisons, and different other places in the community where people live. And also as an academic who's investigating this and understanding some of the broader, wider determinants of how, where, why we die, and the experience at those times. So I want to start first by thinking just about language, and we've heard a bit about the distinction between palliative and end-of-life care, and that's really crucial. But what I think we need to do is take a step even further back, because what we're really talking about here is death, dying, loss, and care, and these are broad population-level events. These are not interventions that only need clinical responses, and that really does separate them from hypertension services, from diabetes management, even from cancer screening, because these are unique, these events, in that they will happen to everyone. And there's very few events that cut right across populations as these. And as a result, they require all sectors to be involved in collaboration across sectors. And so we can't just look either at within, certainly not within palliative care, but even within health, and even beyond health and social care. So we really need to be understanding what real cross-sectoral responses to death, dying, loss and care look like. So there's two key issues that I want to look at. First, looking at the system as a whole, and then going into more of how the system works. So starting with the system. There's a lot of talk about shift to the community, and that is music to my ears and to many of us here. But there has been a discussion about this for some time. And the assisted dying debate recently has focused on end-of-life care and what a good death means. But there's still been a real notable absence of a focus on what dying well at home means, and what a community care response really looks like. And we need to focus on specialist palliative care and hospices, of course, but actually that absence of community care is really notable. And as we know, it's where people want to die. Now, saying where you want to die when you're well, or even at the beginning of a life-limiting illness, is different to in the last days before life, and I spend a lot of time with people working out how those choices might change and what good looks like in an acute setting. But nevertheless, the majority of people we know would like to be at home. But that's not where people are dying in the majority. Now, although the trends are increasing, and that's really encouraging, we still know that the majority of people are dying in hospital, and that there isn't sufficient support to keep people at home. We know people are often coming into hospital in crises or at that last moment. And one of the challenges is with community support at the end of life is that there's a mosaic of providers, and I find this complicated to manage, even to navigate who's doing what. We've got NHS and charitable sectors, social care through adult social care, through continuing healthcare funding, fast track, general practitioners, district nurses, specialist palliative care, and equipment services and transport services. And this is complicated for me to manage when I'm sitting in a patient's home, yet alone if you're unwell or if you're unfamiliar with this. And one of the challenges that follows that is that the lines of responsibility are not clear to patients and carers who are wondering who to call when they suddenly have pain, who to call if they're worried they're becoming less well. Is it rapid response? Is it the 24-hour palliative care advice line? Is it 111? Is it their neighbour? So that's complicated. And even within the professional groups, the lines of responsibility are not clear. And so that is a real challenge. There's also the challenge of what we do in crisis. So we can do a lot of preventative planning, and a lot of that work I'm trying to do in communities and through the research is understanding what prevention looks like in this area, because just because there's a life-limiting condition, there still is a great deal of prevention work that can be done. But we know there's no single number to call. So there's examples through Arthur Rank Hospice with the option 3, end-of-life care through 111, which is an amazing innovation. In North Central London, we don't have that, so we have a magnet with a piece of paper that gives 3 different telephone advice lines to call at different times throughout the 24-hour period on weekends and not. This is really complicated for people to call, and so as a result, people fall through the gaps and call 999 and end up in hospital. So there are some ways that we could begin looking at what a nationwide response to managing crises of care. We know that these crises happen, and when they happen, you need the right advice at that time. And then finally, looking at the wider determinants of health, the social and structural determinants, we know that these social patterns are in existence at the end of life as much as they are throughout the whole life course. And we know crucially that deprivation is a really key indicator for admissions at the end of life, for quality at the end of life. And I think one of the challenges with a lot of the narrative around palliative end-of-life care, advanced care planning, and actually about assisted dying is about choice. And that's very important, and we need to empower people to have that choice. But when you're looking at a population who are suffering from severe deprivation, that choice really is an illusion. And so there's a challenge of actually the issue, where would you like to die? If your home is not able to support that, then that really isn't a choice. And so I can go and see people at home. I can now get hospital beds if the medical equipment services are delivering and etc. Those stars align. But I can get a hospital bed in someone's home. I'll often go back the next day to see them and see that hospital bed is still being used as a shelf for pads and endless Ensure shakes. And I'll ask the person and the family, what has happened? Why are you still on this uncomfortable sofa with your pressure sore, etc.? And they'll say, we hadn't realised that we needed to run this hospital bed through our electricity for 24 hours a day, and we cannot put that on our bill. And so that is a very clear indication of the social and structural determinants that are affecting how people are living and dying, and the role that palliative care services just can't do that. If people are lucky enough to be under a palliative care service, I can get our social workers to start fighting with EDF and get their energy bill minimised. But actually we need to start thinking at more structural levels of how we manage and really support and finance this shift to the community if actually people are setting up a miniature hospital or hospice rooms in their front rooms. So then moving on to the second key issue is that good end-of-life care, good care for people who are dying, grieving and caregiving can not only be provided by clinical services, these are population, societal level events. And the confidence, skills, compassion and relationships that exist are crucial in shaping those experiences. So increasingly we're talking about death literacy, and I've heard the idea of health literacy, digital literacy today, and I think this idea of it being your ability to have the knowledge and skills to make decisions, to navigate the system. And this is increasingly crucial for patients, families, to navigate the complex systems that exist. So death literacy is a term increasingly we're using, and in fact it's been used in some of the parliamentary debates around assisted dying to say people really need to understand a lot more about what's possible, what options are, and then use those skills to navigate and advocate for themselves and their family members. So when we look at building the death literacy of a system, which is where I think we need to be looking, the challenge is that these topics are frightening. They are an assault on ourselves, our loved ones, our mortality, and so people are not often forthcoming in having these discussions. We can't make them otherwise. They are frightening and they do challenge us to look at our own mortality and those that we love. The challenge also is that they're increasingly unfamiliar. Now, this is one of the, this is a good thing, it's an unintended consequence of public health and medical intervention, such that people are now dying later in life. Avoidable mortality, I think the recent statistics were around 22%. So we're looking at unavoidable mortality, something that isn't discussed enough, but actually how, where people are now dying much later in life, people are not seeing people dying in their own homes, children, a number of generations ago, children would have died under age of 5, etc. That doesn't happen. So that's a benefit, but the unintended consequence is that death is unfamiliar. It's hidden within institutions, behind a professional screen, and people aren't seeing that, and that feeds fear. And that means that people don't know how to manage, identify, care for people. When I go to see people at home, one of the first things they say is, thank goodness you're here. I have no idea what's death like. I have no idea how to manage it. Someone's breathing changes, 999, and actually talking about what natural changes happen when someone's dying, how people's hands change, temperature changes, eating, drinking, moving people gently. So these kind of skills used to be more common, used to be more aware, people used to be more aware of them, and they are now really diminishing. So how we build that death literacy amongst our informal caregivers, amongst communities, is a really crucial point. But I think one of the big elephants in the room to join assisted dying sitting at the back is that we are still really based on an acute model of care and an acute model of cure. And implicit in so much medical research, in so much of healthcare, is this idea that death is infinitely deferrable. There's always one more course of antibiotics, there's always one more bag of fluids. And this colludes with this idea that actually we're not all going to die, and that death really is something that we can push back, rather than acknowledging death is inevitable, and death is a part of our human condition. So it's that balance of looking at unavoidable versus avoidable mortality. Public health interventions, oncology, etc., all focused on reducing avoidable mortality. And that's right, because that's where a great deal of the inequities sit. But actually what we're not looking at is that gets smaller and smaller, is this larger amount of unavoidable mortality. How are our healthcare and our social care systems managing unavoidable mortality? So to close, I think we need to build the death literacy system at the same time as fixing integration funding of that system. And I think how we begin looking at much more joined up care is really interesting. And I think that's one of the questions that would be great to have a discussion with now.
Thank you. Thank you so much, Libby. Really interesting to hear that view that if you start talking about death, it's like something you're going to bring it to yourself. And I was saying to some of the other panel members that within the Q&I we had a discussion about writing your will and who amongst the staff had written their will. And half our staff are nursing and half are professional support staff. The nurses had all written their wills. They'd all, whether they got children or not, or whatever their circumstances were. And the professional support staff said, I can't write my will because that will mean I'm ready to die. I'd never even thought about it like that. But what you've just said about needing to open this up, the death literacy, and the changes that we've seen since the Victorian era. Yes. Really interesting. I want to ask you something, but I am going to open it up to the audience. Your role, is that replicated anywhere else? So, is it unusual, and how are you funded?
So is that as my community palliative care role? So all areas should have a community palliative care consultant as part of the community palliative care team. All postcodes should have that. It's quite hard to fill, that's a workforce challenge, but certainly all areas should, and it may come through hospice funding or through NHS funding.
So they acknowledging that they don't because it's difficult to fill
to recruit
role.
To, yeah. And community, no one wants to work in the community, whereas, and that's one of the challenges of being a Cinderella service. And actually that's where real patient-centred care is. And I think we need to shift the narrative so people are proud to work in the community. It's a job you want to take on.
Yeah, thank you. That's really helpful. So rather than have any more questions from me, I'd really like to open this up to the audience. So questions, please put your hand up, say where you're from, and who you would particularly like to direct your question to, or it might be to every panel member. So there's a question at the front here. There's many, many hands going up. Yeah, thank you.
Yeah, thank you. I'm Nadeem Ergal. I represent Strass as an organisation that works with acute sector boards particularly. To the point that was asked at the beginning, which is why is it so difficult to deliver good end-of-life care, you could argue that the ICB integration reform was the best opportunity, and actually the one thing that could prove their value in terms of integration was to take end of life as the first test of integration. And they haven't, because it touches primary care, secondary care, it touches hospice, it touches community assets, and eventually touches the private sector. So if we can't get it right for the end of life through the integration reform, there can't be much confidence for other consumers in healthcare. We did a piece of work in the Borough of London, 380,000 people. We discovered fragmentation that would scare anybody, and trapped value, which is waste, of about 8.5 million. Now, 5 CEOs were never going to individually decide to contract or stop something to improve the system. That was why it didn't happen. 5 CEOs were never going to agree on a building of a system that meant somebody somewhere to give stuff up. So we are really stuck with individual organizations still protecting what they think they're doing well, set against an ICB that isn't delivering integration, set against millions wasted that could benefit staff and patients. So what is the ICB reform for, and what can we do to make the ICB commissioning responsibility, which is now what it's about, make that difference?
Thank you. Was that question directed at anybody or the whole panel?
The whole panel.
Right. Sarah, do you want to say something about that? The missed opportunity with ICBs and not, nobody wants to give up what they do.
In theory, ICBs do have a duty
to provide end-of-life care. It's one specific duty. I think that one of the observations I would have is that people at the end of life are almost hiding in plain sight in the healthcare system. So if you think about the amount of money that we're spending as a healthcare system on emergency care for people in the last year of life, and all of the opportunities that there may be to improve their quality of care by thinking about if they're in hospital for a long time, why is that? How could discharge be improved? Are there other services that could be available, as Libby has described, outside of hospital? Then I think that it's the priority that's placed on end-of-life care relative to other more standard outcome measures for the health system, like A&E, waiting times. I think the opportunity for seeing people at the end of life as being some of those people who are in A&E, who are waiting for treatment, and there just hasn't been the focus at a policy level on end-of-life care that there really needs to be, to see this as a system-wide problem.
Thanks, Sarah. Libby.
Yeah, I think you're absolutely right that it's a really exciting opportunity for cross-sectoral work, the ICBs, and I think also that end-of-life care is a very good case study of how you need integrated working both across health and social care, but across the other sectors, including housing, etc. And I think that one of the roles that the ICB could play, and I'd really like to see examples of this, would be convening all the different parts of the end-of-life care system, or the death, dying and grieving system. So understanding it's a complex system, it's not just having end-of-life, palliative care services or good GP training. Actually, they could bring together social carers, which we know they're not being part of the conversation at all at the moment, the community providers, the local specialist palliative care providers, and actually understanding that system, understanding who does what, because one of the challenges is the fragmentation, the mosaic, and the fact that no one has a clear sense of a line of responsibility or who to call. So actually pulling that across on an ICB level would be something really important to do, would allow that joined up working. And the thing that makes systems work better are relationships. So actually if you have been in the same room and you've met the other providers, you understand that, then you can have much more kind of productive conversations. In our service in Islington and Camden, we, in our MDT, which is held every week, we've now worked closely with our social care providers, and they come to our MDT. They're part of that. It's only been working for about the past few months, which has radically changed everything, because now we go on joint visits with our social care colleagues. We can understand the different dimensions of what health and well-being looks like, rather than just looking at kind of clinical interventions. So things like that, making links across the fragmented system, is where the ICB, I think, holds its power.
That's great. Thank you. Vic, did you want to say anything?
No, I mean, I think that the one of the opportunities perhaps in that space is, as I raised the issue about training, and I think that what the ICB perhaps has the opportunity to do is to think about how it facilitates sort of some shared training and learning. I mean, one of the challenges for any of these complex systems is about people understanding and knowing what each other do and have the opportunity to engage with. So I think thinking through that, but I perhaps share some of your frustration that if you can't get this bit of it right, then the risks for some of the other areas that the ICB needs to deliver on are quite significant. But I think certainly that area around training would be a key opportunity. And I'll go back to my point about being at the table. So in the sense, the ICB missed, in my view, a complete trick around kind of mandating social care provision at the ICB table, and that, I think, leads to all sorts of challenges about how we properly integrate health and care, whether it's through the overall ICB or even through future initiatives such as neighbourhood health services, etc.
Thank you. And it goes back to what Thea was saying right at the beginning. You both mentioned sharing and learning together, and the relationships, building strong relationships to build that trust. Thank you. So I think there's a microphone by... Yes, thank you.
Hello, I'm Frances O'Callaghan. I'm from the North Central London Integrated Care Board. So I'd already put my hand up before the question was asked, but I do feel I need to respond in a very, I hope, positive way. So a couple of things I wanted to say. First of all, we are about to convene our big end-of-life working group, and I'd very much like to ask you to be part of it, Libby. I have acknowledged, in terms of coming back into North Central London, that we are not getting end-of-life right across the board. And as others have said, this is a key responsibility of the Integrated Care Board. So we've already started that conversation, and I'd said to my team, is there an academic? So thank you. I think, secondly, I wanted to just pick up on the point that you made about how we, I can't quite remember the words you used, but the acute model of care and the acute model of cure. And I think really that in many ways this is what's driving the lack of confidence in terms of people being able to think about their families at the end of life. So having been very close to a death in the home, I know that I was absolutely terrified, and the presence of Marie Curie particularly really helped that. But I think because we're not talking about death and we see death as something that happens to other people, we don't have the confidence to see people die at home or in the place that they want to. And I think the most important thing, as well as sort of bringing the people together, it is this concept of the neighbourhood. And I think you will probably know about the work that Marie Curie are doing in Camden with the GPs around Royshaw House. And actually, when I was sitting with them yesterday, I really felt this is the neighbourhood conversation. And I feel that we were talking about long-term conditions, but we talked about end of life as a group of people that the GPs with Marie Curie and others are caring about. And we have a building, and we're doing things on a neighbourhood basis. So I really do think that one of the challenges for me in the ICB is very much about, well, how do I turn this international policy around neighbourhoods? Because I do really think that that's how we're going to navigate that. So thank you very much. It was really good to hear you.
Thank you. You've just been recruited. Yeah.
Fabulous.
And there was, just over here. Can you just put your hand up again? Yep, thank you.
John Dean, Clinical Vice President, Royal College of Physicians. I absolutely agree with the last comment around focus being neighbourhood care, but I think we've got to be careful. I think there's a history in end-of-life and palliative care that we have constrained the people being involved, and some of that's come out in the panel. But I think every professional and every part of the health system has a role in end-of-life care. I currently work in general and acute medicine. I see a lot of people who are nearing the end of life, and sometimes we're providing care for them, but sometimes I'll be navigating them to other people who are doing that. So I have a responsibility, even though I don't directly work in a neighbourhood in end-of-life care. My colleagues who are respiratory physicians or cardiologists or whatever also have a responsibility. So I think it's really important that every part of the healthcare system recognises its role, and that as professional organisations we're quite explicit about that it's everybody's business as well. But I'd be interested particularly in Libby's view about that in terms of the wider involvement of other specialties and other sectors.
Yeah, I totally agree. And I think one of the challenges is around language again. And we did a lot of work around this in the Lancet Commission on the Value of Death that I was leading to try and get how do we understand death throughout our healthcare systems, throughout hospitals, etc. And one of the challenges I think with the term palliative care education is that it's a bit like other specialties, being educated in cardiology and in gastrointestinal. Actually, as you say, this is everyone's responsibility, and death and dying are not unique events to palliative care. And I think palliative care sometimes we have wanted to kind of demonstrate that we've got specialist knowledge because, there's hierarchies in hospitals, and actually you need to evidence that and be legitimised in that. But reading that BBC article that Vic was mentioning, Rachel Clark, who's really vocal on palliative care, she was saying actually the aim is we should do ourselves out of a job because everyone should be so effective at doing this, and really kind of understand that death is a part of life. It's part of us managing healthcare, all healthcare needs from beginning to end. And actually all healthcare workers across different specialisms, across disciplines, should be confident to a different degree, depending on what your day job is. But actually ICU physicians and nurses are managing this just as much without naming it as palliative care. So what I would really advocate for is all disciplines and specialties having teaching knowledge, CPD, etc., on death, dying, grieving and loss. You know, that's the kind of challenge, and we have specialist palliative care which comes in to do that, but actually we manage the complicated parts within that need that kind of specialist team, but everyone should be competent in managing and supporting people who are dying or grieving.
Thank you. Just at the front here, and then over there. Yeah, so second over there. Thank you.
Hi, Dee Therichov. A question for all of you. Have we built trust back with the public since controversies like Shipman and the Liverpool Care Pathway? And is there something about having this open conversation across the life course? So I've got a 7-year-old child, and I deal with death and dying all the time with the nature of work and organ donation. And I've got fantastic resources that we use, particularly with paediatrics and bereavement. But when I went to my child's school to talk about do they have those conversations, there was such a fear about having that. And it is in the PHSE. And there is something about how do we normalise a conversation. So that societal aspect and trust.
Okay, thank you. Do you want to?
Yeah, I think it's very difficult, isn't it? Because, you know, it is frightening. It is terrifying, the idea of dying. And yes, you know, greater literacy on death is really important. I think it's really important that we have these conversations. But can I just wanted to say something that I'm still reeling from what Vic said about the care homes, because my mum died in hospital, but after 3 days there, she'd been in a care home. And when I see, you know, it wasn't a bad place, it wasn't a sort of most basic place. But I mean, the idea of those staff having any training whatsoever, I mean, they didn't really have training on how to get people out of bed in the morning or whatever, let alone on something as complex as that. I mean, how do you improve something like that?
Can I?
Yeah.
Yeah.
Please.
I mean, they will have had training on some of those areas, but I you know that there is a part of their regulation is around training in all sorts of different aspects, but they don't have universal training around end-of-life care. I think that's absolutely the case, and I think, you know, we do need to kind of build on that and build up those skills and expertise. So within the care sector, there's something called the Gold Standards Framework, which is absolutely focused on how to ensure really good end-of-life provision for people. And to have conversations with people and to ensure that they are supported and their family are involved and all sorts of things. I think that, you know, there's obviously lots more work to be done. It's a sector that, you know, it doesn't always get in the news, but there is, when it is in the news, it's often about the chronic kind of underfunding levels within the sector. But that, you know, that doesn't take away from the reality that 20% of people are dying within those homes. So we have to address the fact that that's there, and to think about how we support and ensure for each and every person, not just those who are living within homes which have got that gold standard framework accreditation, but those who are living in homes that haven't yet been able to achieve that or haven't got the resources to even contemplate going through an accreditation program of that sort. I mean, are you reeling from the fact that you don't think that there's capable? So I guess what's the question? What's the sort of?
I suppose the question is, well, I mean, my observation from having been in not only the home that my mother was in, several other homes for various reasons, that those people just don't have any training at all, it seems to me. They're very lowly paid, very low level.
It is absolutely,
therefore,
you know, one of the big issues is about the kind of pay rates within there. I'm not sure that I too spend lots of time, partly on a personal basis because my mum's in a care home, so I'm in and out of care homes all the time, but also on the basis that that's part of my job is going in and out. And I do see lots and lots of people with high levels of empathy, skill in the context of the way they deliver personal care, and management and supervision, etc., that sits behind that. But I think what we haven't got, is a kind of proper, and maybe this is part of this debate, is how do we ensure that everybody who's working in that environment, because they are all going to be part of an awful lot of people's end of life, have the right set of skills to give you confidence as a relative, but also to make sure that the person who, back to the trust discussion, the person on the receiving end of it feels that they're getting the best care they can.
And in a way, their training should be the number one priority.
Well, I would agree that this is, that this is, and that's shifting the whole way we think about this, isn't it? Because I think one of the stats in Sarah's research, was that 85% of all spend on end-of-life care is in the acute sector. So we've got it kind of sort of upside down in that sense, because first, the biggest group of people who do this, and there's colleagues in the room who might want to comment on it, is unpaid carers. So you've got this huge set of people who are, perhaps supported by the care sector, perhaps supported by district nurses, or, coming in and out, but it's the unpaid carers who are trying to grapple with the fact that they too don't know how to have a conversation about death. They too don't know when the breathing changes, should they ring somebody or not. They do, So they're stuck in all of that. Then you've got this big generalist
grappling with the emotional impact of it, actually. As well.
Absolutely. This big generalist workforce that's made up of care workers and made up of, a whole bunch of ancillary staff who are within acute settings, made up of the people who are delivering the beds, to go into somebody, the way you do that sort of thing is a huge part of it, because you're going into the home of somebody whose death is imminent. That's they must understand and know that that's what's happening. But we've kind of got that the wrong way round. But I suppose I would, as you would imagine, want to defend the skills and expertise of those care workforce who are doing the best that they can.
And thank you. And the point being that you've said this a number of times, it's the training that isn't there. Yeah. And then Sarah's point was that if you get it right in one part of the system, it supports another part of the system and takes the pressure off A&E. And those who are admitted to hospital can be safely discharged back to a care home or back home. I think we've got time for 2 more questions over here, and then right in the middle.
Thank you. Hi, I'm Jenny Shand from UCL, and this will be very short because until about a minute ago, Vic, we were talking about training very much about staff and the care workforce, but nobody mentioned unpaid carers. And I'm really passionate that for 25 years we've embedded patient education in the system, and we continue to recognise this army of carers playing really important roles in their families' lives, but we haven't given them bespoke training. So just wanted to encourage that the conversation isn't just about encouraging people to have confidence to have the conversation, but giving them that training. And we did some research, which Libby is aware of, where we interviewed a huge group of carers, and the most consistent thing they said is, I felt most prepared for supporting that death after it had happened. And in the last 24 hours, they could list 5 very specific things that micro-learning would have made a huge difference, would have made them not feel the need to call 999 and go into hospital, would have meant that they felt equipped and confident to manage that situation. So just really keen that education is broader than just the workforce, but recognising that actually we want to upskill and empower individuals in the public as well, and it's more than just conversation. So it's not a question now, but thank you.
No, that's a really, really good point.
It's such a big priority, and the death literacy across the system, and unpaid care is the key people within that, and then social carers, etc., and hospitals. It goes across the entire system. And I think that's one of the urgent challenges that needs to follow the push to community from hospital.
Yeah, thank you. And yes, thank you.
Hello, I'm Sam from Marie Curie, and a couple of years ago, I was really struck by what Mark said at the start about the palliative care being slow to change. Now, a couple of years ago, we did a report with your team, Crystal, at the QNI, looking at caring for people dying at home and some of the challenges around that. And we found 2 big issues. Lack of out-of-hours care and challenges around poverty at the end of life. Now, the notable thing about that report was it was updating a previous report that we did in 1952, which found 2 big issues, lack of out-of-hours care and issues of poverty at the end of life. So I would say there is definitely evidence that as a sector, we can be slow to change. And by God, when it comes to better supporting people dying at home, we really need to change. I think that the findings around spending 4/5 of the healthcare money spent on people at the end of life in hospitals, the fact that 3 in 10 patients, inpatients in hospitals are in the final year of their lives. People are spending up to 40 days of the last year of their life in hospital. People don't want to be spending that time in hospital, and we know it would massively reduce hospital pressures if we could change that. Now, the most frustrating thing about this is that there are proven models with effectiveness at reducing hospital admissions at the end of life. Libby, you mentioned the Arthur Rank model of the 111 999 alternatives that reduce 999 call-outs. We know ambulance services are doing some really interesting stuff about supporting paramedics to deliver better palliative care, which reduces conveyances. We know from our own practice that working in emergency departments can have really profound impacts on the numbers of people who are admitted to hospital by diverting into community services. The challenge is these are massively piecemeal. There are bits and pieces all over the place, and there is no system for enabling them to be scaled up. And until there is, we're just going to have bits and pieces of practice in place, and we're still going to be spending 4/5 of the money that we spend on people at the end of life in hospital. So my question is, and to be honest, it's to anyone who can answer it, is how on earth do we scale up those proven models of practice that can avoid hospital admissions at the end of life?
Thank you, Sam. And let's hope that we're not doing the same research in 50 years when probably neither one of us will be here and finding the same thing. But a really, really good challenge. And actually, you've done me a favour because we are almost out of time. So what I'm going to do is put that question to each of the panel to wrap up. So how can we scale the good practice that is out there? Because it's not all a disaster. There is some good practice. How can we intentionally scale that? And I'll start with Mark. How are we going to make it better? If it exists in one place, how can the system get it better?
How can it? Make Libby and Vicky Secretary of State for...
Take it up. We'll take it up.
If necessary.
Those that understand, yes. And have them advising.
I suppose you do need good advice, but I mean, I don't know, it's money in the end, isn't it? I mean, that's the trouble with the whole discussion today. To me, a lot of it comes down to money, and you're not going to get the money. I mean, you can do everything with... Well, you can't do everything with money. You still need good practice.
And you might need to double run for a while you're...
Yeah.
One thing continues to run while you're transferring to another part of the system.
I don't know enough about the health service to know how you'd actually improve it. But I am struck by the idea of improving death literacy, the conversation around that. And I felt that for a long time, but I don't know how you do that either. I have no answers, but I mean, only questions. But that's what you get when you have a journalist on the panel.
Yeah. Thank you.
I mean, how do you improve the conversation about the end of life generally? I think that's really urgent.
Yeah, it is. And that whole idea of death literacy, and to Dee's point, throughout the whole of the life course, actually, starting with children.
And I suppose also a general point is that we hear a lot about postcode lottery, but isn't that what the system dictates? Because we are, to use your word, a mosaic of healthcare. So I don't see how your good practice where you are can necessarily be applied to Barnsley or Banstead, you know that. Because there are going to be different individuals there. And different...
Unless Libby becomes Secretary of State.
Exactly.
Yeah. Or at least advisor too. Thank you, Mark. Libby.
So I think one of the big challenges is around people's understanding, knowledge, confidence to have these discussions. Calling it death literacy is a way of understanding that, and how we increase that across different parts of the sector. So one of the questions, one of the levers I'm looking at using is obviously research, but I think we have enough to know what's wrong and what the interventions are needed. So through the Lancet Commission on the Value of Death, we're looking at holding a really big global conversation on this and actually taking it out of healthcare and putting it into a much bigger public level. I was really interested in the biggest conversation that was happening earlier to think how can we really take that in. And I think journalism has a really key part in that, actually facilitating this discussion out of the end-of-life care, 3 days, 3 months, 3 weeks. It's too late, it's too soon when you're in a crisis. And I think the other way is looking at the ICB mandate and really thinking about how that can be done, because obviously it's a mosaic within that, but each ICB is going to have to look at its particular wider determinants of health and actually situate that end-of-life response within that. But I think the idea that they are convening, looking at models like the REACT model in Bradford, the Arthur Rank 111 model. I mean, I'd love to see 111 option 3 end-of-life throughout the whole of England, if not the UK. I think that's a really simple question. There's research looking at mental health options as well, and actually can we make 111 as that central funnel where everyone goes through something more equitable? So I think that would be my number one. But I think the next thing is for ICBs to use end-of-life care as a case study to convene a conversation, relationships develop, and then you can start looking at what best practice would work here, and then looking at scaling that across the ICB with the neighbourhoods as your kind of micro units of change. I think that's where we'll really see that, and running death literacy through vertically and horizontally across the systems.
Thank you. Thanks, Libby. Vic?
Well, the solution often that colleagues and I talk about in this, because it's not a sort of single issue, is it? Why is it so difficult to scale things? Is make it part of a soap opera and make it a storyline that absolutely everybody relates to and talks about, and and everybody wants to make sure that they've got a Libby in each and every kind of, that becomes a recognisable role, and then people start to ask questions, whether it's local councillors, whether it's whoever, why haven't we got that type of thing? But in the absence of anybody here necessarily having the sort of hotline to, well, maybe Mark, you do, the hotline to that, then I guess I suppose the other bit is realising why some of this is so difficult. So I think is it that people are frightened of death? Possibly. Is it that people are actually also very frightened of old age, of disability, of frailty, of dependency? And actually, if most of the imagery or the thought of death is around age as well, there's an awful lot of ways in which. And also, I think part of the reason we get it so wrong, and I think this is maybe I'm very happy to be shouted down, is because actually if we get it wrong, the person who we got it wrong for isn't there anymore in some senses. So, and this is, I think, part of the challenge, not for social care, is that often a lot of it happens, it's behind closed doors, it's invisible, it's not the voice, people don't have a loud voice, they don't have a loud, there's not a lot of sort of advocates in that sort of sense, very public advocates. So I think it is part of a bigger debate around how do we talk about ageing, how do we create communities that recognise and value ageing. We can learn a lot from other countries. Nuffield is brilliant at all of its international work, that there are other countries where ageing is much further advanced, in Singapore or in Japan and other places where there's different ways in which we think about ageing. And I think that also creates different ways that we think about death and end of life. And I think that's part of a transformation. We know that I can't remember, Ona was giving a stat earlier on about the huge rise in people over 90 that we'll have in the next 10 years. We are going to have to shift our whole discussion about how we see and view society and view older people within that, and how we challenge ageing. And actually, if we get really good at human rights for older people, I think we'll get an awful lot better at end-of-life care for everybody.
Yeah. Thank you, Vic. And we'll finish where we started with Sarah.
Thank you. So I think what I would add to all of those points is that I think that we could use evidence and data much better at a local level to understand what kind of services are available in each area, how are they being used, where there are gaps, where within an ICB, for example, there is higher use of emergency services and what is available. And I think that could really spur actions that could be taken at a local level by ICBs, by primary care networks, thinking about schemes like the Enhanced Health and Care Homes programme that could make a real difference.
Thank you, Sarah. I'm not going to try and sum up because I think you've all done that so brilliantly with giving us your own summaries. I'd just like you to join me in thanking Mark, Libby, Vic and Sarah for such a great session.